Hey guys, so this week I had another sad day where I had to help certify the death of one of our patients in aged care. I work as a medical assistant in aged care, and one of the tasks that I have to help out with is certifying deaths. But things are a bit different now to what they used to be since COVID restrictions have started. And I thought I would kind of talk a bit about that and hopefully share some insights to you guys, maybe to make you realize that when someone dies during the time of COVID, it's not, an old person who's surrounded by their family and having a beautiful departure of this life. Often it's extremely lonely because of the restrictions on visitors. So I'll tell you about the story of this gentleman. So Mr. K was 99 years old. His birthday is next month. And he has prostate cancer, or he had prostate cancer. And most prostate cancer is usually pretty slow growing, and often people will die with prostate cancer, not from it. However, some subtypes are nasty like his. And as you know, with the anatomy, you have the kidneys, the ureter, the bladder, the urethra, and that first part is the prostatic urethra, and his prostate was so cancerous that it was blocking that urethra. So he had essentially a backup of fluid that was damaging his kidneys, and he died from kidney failure. Now, no one really cares about the medical side of things when it comes to death. It's really about his loved ones and family. And he was closest with his carer. His carer was his daughter-in-law. He and his son had a good relationships for all intents and purposes. They were very cordial from what I saw, but you could tell that it was quite a formal relationship, with respect, unemotional and not very warm. But the son was the kind of decision maker of the family, and he was also the guardian to Mr. K, this gentleman. And so therefore was also the allocated visitor for Mr. K. Now, one of the precautions for COVID is this thing of allocated visitors, where hospital patients can only have one visitor visit. And it's not one visitor per day, it's the same visitor throughout their stay. In aged care, I'm seeing people who are staying at hospital up to a month, sometimes 2 months. And that can actually be really straining for the visitor because it's hard for them to take a day off. If they take a day off, then their loved one might become upset. It's just really hard. But in Mr. K's case, his visitor, the allocated visitor, was his son, which was nice, and the son was coping, but was lacking the closeness. But the person he was closest with was really his daughter-in-law, who was his carer. Now, when patients go onto the palliative care pathway, palliative care is essentially symptom management and end-of-life care. So it's basically the team of doctors that don't try and fix your medical problem. They don't try and make you live longer. They try and make you live more comfortably. And sometimes they'll be used for symptom control in people who, have a pretty good prognosis, but often they're used for symptom control with people who have a bad prognosis. And eventually the family came across the idea that Mr. K was having a pretty bad prognosis, and the end-of-life care pathway, which is kind of activated when the palliative care team take over care, that was only activated on Monday. Anyway, I come in on Tuesday morning. Since it was activated on Monday, it actually gives you an exception. It allows more visitors to come and visit you. So he was due to see his daughter come in on Tuesday. However, it was Tuesday morning at about 8:30 when he died. I had come in about 7:30 as I normally do, had my cup of tea, I had seen him, he was awake. He kind of looked a bit confused, but unfortunately that was his baseline. He was often quite confused. And yeah, as I was making my cup of tea and starting to prep the notes, he passed away, and the nurse just came in saying he died and we need to go certify his death. The other thing is there are quite strict visiting hours in the day, and they start at 10 a.m. But I'm sure his son would have loved to be there earlier if he could have. And so he died without his son or his daughter-in-law seeing him. I thought this is an important message to share because, you hear it often where it's like people are thinking, old people are going to die anyway, let COVID take its toll and all these things. And by all means, being in lockdown is not a benign activity for society. There is a lot of, quality and disability adjusted life years being added to society for being in lockdown. And at the end of all this, we can weigh the pros and cons of whether we should do lockdown for the next pandemic or not. But nevertheless, it's important to make this point that a lot of people are dying alone because they can't get visitors. And I think COVID restrictions are incredibly important. That's not the point I'm trying to make. The point I'm trying to make is we want to beat this thing as quickly as possible so that this doesn't affect more people than it needs to. I think it's really important to have a good death, especially now when we can provide good deaths. It's a strange thing to say, but we now have really good medicines and we can now coordinate care and have the right family, and people can pass away in their home, and people can die well now. It wasn't always the case, So I thought I'd also talk about, how to certify a death. I realized that probably a lot of people watching this, whether you're students or whether you're just interested in healthcare rants or stories, healthcare stories, I should say, a bunch of you probably have never certified a death, and it is quite thorough, I guess. There's quite a number of things to do, and so I'll just explain it to you. The first thing you do, you're usually not there when someone dies. If you're there when someone dies, you got to switch on, and the first thing you have to do is ask to check the resuscitation status, especially in aged care. If you're on the ward and someone stops breathing, you go to resuscitation, right? You go for chest compressions, call for help, airways, breathing, cardiovascular, blah, blah, blah. That's not aged care a lot of the time. A lot of people in aged care have got advanced care directives that state that they are not for resuscitation, because doing the resuscitation won't bring them a quality of life that they are willing to accept. And neither would I a lot of the time. So the first thing you do if you're right next to them is check the NFR status if you don't know it. NFR not for resuscitation, by the way. If you know that they're not for resuscitation and they die, just take a deep breath, all right? And do your review. So first thing you do is you actually speak to the deceased. You say, "Hello, can you hear me? Mr. K, can you hear me?" If they don't respond to voice, you can listen to their chest for you should listen to their chest for 2 whole minutes. You're listening for heart and lung sounds. And while you're doing it, 2 minutes is a long time, but you kind of observe this sickening stillness of a deceased body. And the color changes and the eyes change, they become glossy and cloudy. And after you've listened for 2 minutes, this is where it's not that nice, but you got to do a pain sensation. You need to see if they respond to pain. So you do a trapezius squeeze or a sternal rub. And if there's no response, there's a couple of other things you have to do on this checklist, but essentially then you say, may you rest in peace, Mr. K. Time of death is 8:30 a.m. And really, for an intern or a junior doctor, that's only the start of the story. There's actually a lot of documentation you have to do, and rightly so. And I'm not complaining about it, but you have to fill a bunch of government documents. The first document is this big A3 cause of death certificate, and you describe what was the cause of death, and you fill in a bunch of details and that kind of thing. And that's really just about understanding the reason that someone died. The next document's interesting. It's the coronial checklist. And this is, asking you questions whether you think it was a suspicious death, whether the person was a child in custody, whether the person was, in an aged care home. There's a set of questions that will always get the coroner to review the case. So if they're a child, or if they're within 24 hours of anesthetic, they'll always review that case, and then the coroner will decide whether it's a suspicious death and have to investigate it. So you usually fill that checklist. Luckily for all the deaths that I've had to certify, it's always been not a coroner's case. And the final document is, to be honest, a little bit weird. It's this checklist to ensure that there's no battery-operated device in the body. And the whole purpose of it is to ensure that it's, the body is safe for cremation. And I get it, that's an important thing to do, but it's just kind of feels out of place when you're talking about cause of death, and then you're suddenly being like, does he have a pacemaker, and is he safe to be cremated? It's like, guys, are we up to that yet? Let's have a breather here. Anyway, that is one of the jobs that the junior doctors have to do. pretty interesting actually. I get much more emotional about these cases like now, like after, you know, today's Sunday, this happened all on Tuesday, but once I get home and I get out of that kind of medical guarded mode thing, and when I get home, you know, the armor is lowered and I feel much more vulnerable to the emotions and stuff. And that's okay. But yeah, it's just really sad. All right, guys, that's it from me for today. This is a new style of video, by the way. So if you enjoy it, I would really like feedback on it. It's less scripted. It's also less YouTuber, like I'm being less loud, being more kind of, I guess, intimate with you guys and honest. And if you guys like that, I need to know, because I prefer doing it this way as well, actually, to be honest. All right, I'll see you guys next time. You're always welcome here, and please consider subscribing. Have an absolutely lovely day. Bye for now.